Happy Thursday, everyone. Welcome to today's webinar, Implementing Quadruple Medical Therapy for Heart Failure with Reduced Ejection Fraction. My name is Natalie Navarre. I am the Senior Program Development Manager for Get With the Guidelines Heart Failure, Coronary Artery Disease, and Resuscitation. Before we get started, I'd like to go over a few housekeeping items. This webinar is being recorded and will be sent to you via email within 24 hours. There are no CEs associated with the webinar, but we can get you a certificate of completion in your follow-up email after the conclusion of the event. You have the opportunity and are encouraged to submit text questions by typing them into the questions panel of the control panel. You can send in questions anytime during the presentation. We do have a few questions pre-prepared, but we will get to as many of your questions as time allows. If you experience any technical issues during the presentation, most can be resolved by refreshing your browser. To view live closed captioning for the webinar, please utilize the hyperlink in the chat box. Dr. Greene, next slide. Next slide. Our presenter today is Dr. Steve Greene. Dr. Greene is a heart failure cardiologist and assistant professor of medicine at Duke University and the DCRI. He has been a co-investigator and co-author of national and international heart failure trials, including the Astronaut, Socrates Reduced, Compose, and Transform heart failure trials. He has led multiple analyses from national registries characterizing the quality of heart failure care in U.S. clinical practice, including studies leveraging the CHAMP Heart Failure Registry, the AHA's Get With the Guidelines Heart Failure Registry, and the Victoria Registry. Dr. Greene's work has led to more than 300 publications in peer-reviewed journals. Next slide. Our moderator today is Dr. Vanessa Blumer. Dr. Vanessa Blumer is set to join Inova Schar Heart and Vascular Institute as a member of their Advanced Heart Failure and Transplant Cardiology faculty. She will hold dual roles as Medical Co-Director of Heart Failure Outreach and Associate Director of Heart Failure Research. Dr. Blumer received her MD from the Universidad Central de Venezuela with an honorific distinction in research. She served as a chief resident at the University of Miami-Jackson Memorial Hospital, pursued a cardiovascular disease fellowship and one-year cardiovascular research fellowship at Duke University and the DCRI, and recently completed an advanced heart failure and transplant cardiology fellowship at the Cleveland Clinic Foundation, where she was named Fellow of the Year. She serves as early career editor international engagement for the Journal of Cardiac Failure. Her research interests encompass clinical outcomes of acute and advanced heart failure patients, cardiogenic shock, mechanical circulatory support and heart transplantation, health disparities, and novel training pathways for the overlap of heart failure and critical care. And now I would like Dr. Greene to go ahead with his presentation. So next slide when you're ready, Dr. Greene.
All right, well, thanks so much, Natalie, for that kind introduction, and welcome to everyone in the audience. I'm really excited to be with you this afternoon. We'll be discussing implementing quadruple medical therapy for heart failure with reduced ejection fraction. These are my disclosures. So let's start by putting heart failure risk in context. Now, across so many different fields of medicine, we're so used to hearing the term high risk. You almost get numb to it, hearing about whatever specialty you're talking about. There's seemingly so many high risk phenotypes out there. But important to recognize that not all high risk conditions are created equal. That it's important to anchor that subjective term, high risk, with actual absolute risks of bad clinical events happening. And again, doing so, you'll realize that not all these high risk conditions are created equal. And conveniently within cardiology, we have the lipid guidelines, which for some years now have been using terminology like low risk, borderline risk, intermediate risk, high risk, and even the term very high risk. And what they've been doing is anchoring those relative terms to the actual absolute event rates using the pooled cohorts equation. So just to summarize, for example, the cholesterol guidelines would call someone as being high risk if they had about a 2 to 5% per year risk of heart attack or stroke. And they would call someone as very high risk if they had about a 5 to 8% per year risk of heart attack or stroke. Now, while I certainly would agree 5 to 8% of a heart attack or stroke certainly seems like very high risk to me, I wouldn't want that to be my own risk of heart attack or stroke per year. But if 5 to 8% is very high risk, what on earth are we going to call our patients with heart failure? Even our most stable, quote unquote, heart failure patient, the patient is NYHA class 2, that's never been hospitalized, that comes into your office and smiling with no complaints at you. That person has a 1-year risk of cardiovascular death or heart failure hospitalization of 10% per year. Risk in heart failure populations doesn't get much lower than that. And then the risk of CV death and heart failure hospitalization goes up exponentially among our sicker heart failure patients, the patients who have been hospitalized with worsening heart failure episodes, for example. They're talking about a 1-year risk of CV death or heart failure hospitalization of 40% per year. So again, if we're going to call things in atherosclerotic cardiovascular disease world very high risk, I think in the heart failure world, we need to be acknowledging that heart failure is an extreme high risk condition or very extreme high risk condition. Well, with that being said, if heart failure is an extreme risk condition, you would think we would treat it with a sense of urgency, right? But unfortunately, no. Paradoxical to heart failure as an extreme risk condition, what is the status quo approach to therapy? Well, the status quo approach to therapy is a slow, take your time mentality, serial and selective approach, one medication change at a time. And for example, in routine clinical practice, a traditional heart failure diagnosis and care plan might look something like this on this slide. You have a patient newly diagnosed with heart failure, start them on an ACE inhibitor, maybe you start them on a beta blocker at the same time. Well, you start those medicines, wait a few weeks, ensure tolerability. Then you might up titrate the dose, wait a few more weeks, ensure tolerability. Then after they've been on those therapies for a few months, you say, okay, well, now's the time to add an MRA. So you add spironolactone, you wait a few more weeks, ensure tolerability, up titrate the dose. Again, make sure the potassium's okay, wait a few more weeks. Then you say, okay, well, now it's time to switch from an ACE inhibitor to ARNI. You do the washout of the ACE inhibitor, you start the sacubitril valsartan, up titrate the dose, wait a few more weeks, up titrate the dose. And then finally you say, okay, well, now it's time for quad therapy. Let's start an SGLT2 inhibitor. And while very well intentioned, this one move at a time, serial and selective approach can take up to 28 to 56 weeks before GDMT is fully implemented. And at each step, there's multiple things that get in your way of success. There's missed clinic visits. There's hospitalizations. There's also, you succumb to clinical inertia where the patient and the clinician are saying, oh, well, you know, the patient's feeling fine today. Why do we need to rock the boat? And while the patient is on this long circuitous pathway towards optimal VDMT, they're needlessly exposed to excess risk of death and clinical worsening the entire time. Well, what does a status quo, slow and serial approach get us in routine clinical practice? Well, it gets us what we saw in the CHAMP HF registry. This was a registry in the United States of outpatients with heart failure with reduced ejection fraction. And we saw that when we followed patients over time, clinic visit to clinic visit, there was minimal initiation and titration of GDMT in outpatient US clinical practice. It really was this culture of what I call set it and forget it. You make an initial decision about GDMT and you just let it ride indefinitely. And in the CHAMP HF registry, this minimal titration of GDMT was ongoing despite patients coming in generally clinic visit after clinic visit with blood pressures generally greater than 120, EGFRs greater than 60, but our clinicians, as clinicians, were falling asleep at the wheel and not optimizing medical therapy and getting good value for these in-person clinic visits. But then we see the same phenomenon with our status quo approach and culture for the patients that are hospitalized for worsening heart failure. Hospitalization is an opportunity to optimize heart failure medical therapy. Yet, when we look at the Victoria registry, which is from patients hospitalized for worsening heart failure in the United States and North America, as shown on this slide, patients came into the hospital on low doses or not on medical therapy at all, generally speaking, and they left on stable sub-target doses or no medication at all in most circumstances. There was minimal initiation and escalation of GDMT during hospitalization. And this culminated at time of discharge when the vital signs showed that the median blood pressure was 110 to 120, EGFR 50 to 60. Again, both suggesting there was likely ample room in many cases to escalate and optimize GDMT. But despite those characteristics, when you look at the percentage of patients that were eligible but not discharged on therapy, you had 1 in 3 eligible patients not go home on ACE, ARB, ARNI. You had 1 in 4 eligible patients not go home on a beta blocker, and you had more than half of eligible patients not go home on MRA. But even for our newer therapies, unfortunately, we're seeing history repeat itself. And these are newer data from the Get With the Guidelines Heart Failure Registry looking at SGLT2 inhibitor use in the United States among eligible patients hospitalized for heart failure with reduced ejection fraction. These are from a time period of 2020 and 2021. And you look at eligible patients, only 1 in 5 eligible patients were prescribed an SGLT2 inhibitor at time of discharge. Less than 1 in 4 of patients with a triple indication. Not only did they have heart failure with reduced EF, they also had CKD and type 2 diabetes. That subset of patients, less than 1 in 4 were discharged on an SGLT2 inhibitor. And then when you look at quad therapy, really the state of the art for patients nowadays with heart failure with reduced ejection fraction, less than 1 in 10 discharged on quadruple therapy. But we also know we have a major quality of care problem by simple fact that we can look at hospital level variation. Some hospitals in the United States are doing this a whole lot better than others. So on one hand, this should let everyone know that it can be done and that we should have confidence that we can try to get all the hospitals to try to get on board. But just looking at these data on hospital level variation and Get With the Guidelines heart failure, only 4% of hospitals were discharging the majority of their eligible patients on SGLT2 inhibitor. But in contrast, we had over 6% of patients discharge 0 eligible patients. Get that, 0 eligible patients on an SGLT2 inhibitor. So we have the full spectrum of how often SGLT2 inhibitors were prescribed, but unfortunately there were more hospitals prescribing 0 than there were hospitals prescribing them in the majority of their patients. But aside from when you discharge patients not on GDMT from the hospital, sure, we of course are exposing them to excess clinical risk, and these are the patients that are highest risk, they need all the help they can get. But unfortunately, aside from exposing them to the excess risk, we are unfortunately destining them to either never getting the therapy at all or only getting the therapy after substantial delay. Well, what do I mean by this? Well, these are data also from the Get With the Guidelines Heart Failure Registry over time, which show that what you do at time of hospital discharge matters so much, not just for the short-term therapy the patient will receive, but also you're setting the stage for the long-term therapy. So for example, this graph here shows if you have patients eligible for a therapy at discharge, whether you're talking about beta blocker, ARNI, or MRA, they're eligible at time of discharge. Whether you prescribe that therapy or you choose to defer, major implications for their chance of getting that therapy at all over 12 months. So for example, with ARNI and MRA, for example, you have a patient eligible at discharge, but you defer. You say, well, you know, my job in the hospital is just diurese and discharge. I'm not going to step on the outpatient cardiologist's toes, let them prescribe spironolactone, for example. That approach, despite being potentially well-intentioned, destines your patient to have more than a 75% chance they will not get ARNI or MRA during the entire 12 months after they leave the hospital. Clinical inertia takes over when they leave the hospital. And again, deferring equals either never initiating or at best substantial delay. But while gaps in GDMT have been repeatedly shown in Get With the Guidelines Heart Failure, CHAMP-HF, and many other registries worldwide, you know, a central issue is, well, why do these gaps exist? And conversations happen all the time about this, but what I would say is let's distill potential barriers into really 4 key buckets. You know, one potential barrier might be a clinician reason, where the clinician, for lack of education on the issue or paying attention to the issue, does not recognize the opportunity for GDMT in an eligible patient. A second bucket might be a medical reason. Maybe a clinician recognizes that GDMT is missing, but judges that GDMT is not appropriate or contraindicated. There can also be a third bucket called, like I would call patient decision or patient request, that starting another medicine even after having a well-informed discussion with the patient, is not consistent with the patient's goals. And then also is the systems-based reasons. These are things like out-of-pocket costs, drug formularies, or social determinants of health at a system level that get in the way of optimal GDMT. But as we discuss some of these barriers, I think the first one that I'll discuss quickly is the system level barrier of out-of-pocket costs, because I think in conversations this gets by and large the most attention. And what I will say is that, of course, anyone who sees patients, we know that there are select patients where out-of-pocket costs, insurance coverage get in the way of optimal GDMT. We have to acknowledge that that is the key barrier for some patients. But what I'm also here to tell you is that based on the data, we can say with confidence that out-of-pocket costs are not the dominant reason for the widespread systemic underuse of GDMT that we see. And we know that for a couple of reasons. One reason we know that out-of-pocket costs is not the dominant reason is because major GDMT gaps exist among eligible patients, even in environments where patient costs and access are much less of an issue. In the United States, we have the VA health system, which again, for veterans who are even partially service connected, there are minimal to no costs for their prescription drugs. But yet we see drugs like sacubitril, valsartan, MRA. In this system where cost and access should not be an issue, we have only about 30% use of these life-saving therapies. And then even with SGLT2 inhibitor use, on the panel on the right, a recent analysis from the VA health system looked at patients that had heart failure, but also diabetes. So they had at least 2 indications for an SGLT2 inhibitor. Half of them also had CKD, so therefore had 3 indications. But despite multiple indications for an SGLT2 inhibitor in the VA health system, only 15% of our veterans were prescribed an SGLT2 inhibitor, and no VA center prescribed more than 30% among eligible veterans. But aside from the example of the VA health system, we have a second way that we know that out-of-pocket costs are not the dominant reason for widespread GDMT underuse. And that's because even for our generic therapies, there are major gaps in use. It's not just the branded therapies like sacubitril, valsartan, or SGLT2 inhibitors, even our generic therapies, enormous gaps. And we looked at this, for example, in the HF Registry. Again, eligible patients with HFrEF in the United States, proportion of patients not on an ACE inhibitor or ARB, more than a third not on a beta blocker, 2 out of every 3 eligible patients not on an MRA. And when you put it all together, even for this triple therapy, a fully generic triple therapy regimen of 3 life-saving drugs, less than 1 in 4 eligible patients were getting this completely generic triple therapy regimen that is estimated to cost about $160 per year. Again, life-saving drugs. By comparison, a newly approved cancer drug in the United States in the year 2021 cost about $283,000 per year. And I would go out on a limb and say that the evidence supporting the average newly approved cancer drug pales in comparison to the evidence associated with ACE and ARB, beta blocker, and MRA. So again, we have substantial work to do even with our inexpensive generic therapies. But aside from those system level barriers like out-of-pocket costs, oftentimes clinicians will say, well, the gaps exist because the patients I see in the office, they all have low blood pressure, and I'm really worried about blood pressure lowering when I start GDMT. Well, sounds okay, and I get it, these drugs oftentimes can lower blood pressure. When you take a step back and look at the data, we see that there are large gaps in GDMT, even among the patients with quote-unquote blood pressure room. These are data from the HF Registry, which show that whether the patient had high blood pressure or low blood pressure, by and large, the gaps in GDMT were completely the same. Again, strongly suggests a quality of care issue, strongly suggests we're falling asleep at the wheel, that it's less probably about blood pressure when you're looking at the widespread systemic underuse of GDMT. But if it's not blood pressure, well, what about kidney function? This is something that clinicians also are very preoccupied and worried about when they're initiating and titrating GDMT. And yes, absolutely, there are certain medications that have absolute contraindications when it comes to very low GFR. So for example, MRA is contraindicated for initiation when eGFR is less than 30, SGLT2 inhibitor with eGFR less than 20 for initiation. But we see that even among the eGFR ranges well within the eligibility criteria for these therapies, again, substantial gaps, in that as GFR falls, we're more likely to prescribe appropriate therapy. And again, even within the eGFR criteria, well within eligibility. So for example, let's look at MRA here on this slide, which is showing, again, data from the Get With the Guidelines Heart Failure Registry. Looking at eGFR 45 to 60, that brown color, only 1 out of 3 eligible patients with HFrEF were discharged on an MRA, despite 45 to 60 eGFR being, again, well within the eligibility criteria. And you see as eGFR falls, even within eligibility criteria, you see the use of GDMT falls as well. And this is unfortunate because the patients with comorbid CKD and with decrements in their kidney function, they're actually at the highest risk. They need all the help they can get, yet they are less likely to get appropriate disease-modifying therapy, again, despite being eligible. So to combat what I would call a systemic culture of clinical inertia and GDMT underuse, my friends, my colleagues, and I, we proposed back in 2021 the idea of simultaneous or rapid sequence initiation of quadruple medical therapy for heart failure, focusing on the need to optimize therapy with speed. And this would involve starting all 4 mortality-reducing drugs for HFrEF without delay on day 1 or in rapid sequence within 1 week. And this would apply to both inpatients or outpatients with a focus on initially low doses of ARNI, beta blocker, and MRA. There's only 1 dose of SGLT2 inhibitor. And once you get all 4 of those evidence-based therapies on board, then you focus on up titration over the coming days to weeks. And the following year, in the 2022 ACC/AHA heart failure guidelines, we had simultaneous initiation be acknowledged. Importantly, not only did these new guidelines talk about the what we should be doing, and of course they talk about now the 4 pillars with the new addition of SGLT2 inhibitors. So they talk about the what, and you see how powerful those 4 pillars are in the upper left-hand side of the slide. You see about a 73% relative risk reduction with all 4 as the projected benefit, a number needed to treat less than 4 to save a life over 2 years. But again, not only do the guidelines talk about the what, but they also talked about the tempo and the urgency with what we should be doing with our GDMT. The guidelines acknowledge now that these step 1 therapies, these 4 pillars, may be started simultaneously and may be started without a specific medication sequence that we're preoccupied with, and that they may be started and should be started without delay. Well, okay, sounds nice, but what is the rationale and evidence for simultaneous or rapid sequence initiation? Well, really the backbone of this approach is recognizing that for each of the 4 pillars, the clinical benefits appear within not weeks to months to years after the drugs are started, but just within days to weeks following initiation of any of the 4 drugs. You see very early separation of event curves, such that you can easily understand that delayed initiation of any of these medications in an eligible patient equals needless exposure to excess clinical risk. And remember how we opened up the session today talking about how heart failure really is an extreme high risk condition. Well, these patients need all the help they can get. And not only do these 4 pillars act on reducing clinical events very quickly, but they're also fully additive. The benefits of beta blocker are incremental to ARNI. ARNI is incremental to MRA. That the 4 pillars really are the way to get the additive benefits and try to lower an extreme risk condition, the risk with that condition, as best as possible. But it's not only about efficacy. The idea of simultaneous or rapid sequence initiation may also pay dividends because the therapies actually work together to enable tolerance of each other. So for example, SGLT2 inhibitors, they decrease the risk of hyperkalemia. They also slow progression of kidney disease. Likewise, sacubitril valsartan compared with an ACE inhibitor decreases the risk of hyperkalemia among patients on an MRA. But these benefits aren't just on like lab values like serum potassium or EGFR. SGLT2 inhibitor and ARNI might also lead to less MRA discontinuation. So for example, on the left-hand side, you have data from Emperor Reduced with empagliflozin. Among patients on MRA at baseline, empagliflozin came with a 22% lower likelihood of discontinuing MRA during follow-up. Likewise, sacubitril valsartan compared with an ACE inhibitor, clinically and statistically significant lower chances of MRA discontinuation during follow-up. So you can easily understand that delayed initiation of an SGLT2 inhibitor or delaying that switch from an ACE inhibitor to an ARNI needlessly exposes the patient to excess risk of hyperkalemia and also MRA discontinuation. And again, remember, MRA in and of itself is a life-saving therapy, and it also needs all the help it can get. Generally speaking, more than half of our eligible patients, or upwards of 2/3 of our eligible patients, are not prescribed an MRA. SGLT2 inhibitors and ARNI, we have strong evidence that they not only help lower outcomes themselves, but they also encourage persistence and adherence to MRA therapy. But of course, whenever you're talking about starting multiple medications potentially at the same time, some out there will be hesitant. And one of the common questions I get is, well, Steve, sounds all well and good, but won't starting multiple medications at once increase the risk of medication intolerance? And my quick and easy answer is, well, there is no objective evidence whatsoever that simultaneous or rapid sequence initiation increases the risk of medication intolerance. There's just no evidence for that. In fact, we just showed evidence that it might in fact improve tolerability of medical therapy by starting these medications simultaneously or in short order. But to address this comment, there's another few comments that I'll say that put this in context. Is one, that tolerability of the approach of simultaneous or rapid sequence initiation is enhanced by initiating low doses at the onset. Carvedilol 3.125, for example, sacubitril valsartan 24-26, spironolactone 12.5 milligrams daily. Point number two, I'll say, is that 2 of the 4 therapies, SGLT2 inhibitor and MRA, rarely cause symptomatic side effects in and of themselves. And then point number 3 is perhaps the most important. And that's to say that HFrEF disease progression may be misinterpreted as a medication-related adverse event, and that this disease state worsening is much more likely if initiation of any of the 4 medications is delayed. Well, what do I mean by this? Well, take, for example, on the right-hand side, these are data from the Emperor Reduced trial. And on the y-axis, you're showing the odds ratio for a change in NYHA functional class. So you see that within 4 weeks of study drug initiation, the chances of NYHA either improving or deteriorating go in completely different directions, whether you start with someone on empagliflozin versus placebo. So to take this into account clinically, what this means is, let's say you have someone in your office today, they're feeling fine, but they're eligible for an SGLT2 inhibitor. Well, you decide not to rock the boat because they're feeling fine today. Well, you then increase the chance that when they 4 weeks from now, they might come back with worsening NYHA class. Now they're having worsening fatigue and shortness of breath. And then when you see that patient 4 weeks later with this worsening fatigue and shortness of breath, now you're asking yourself, well, maybe this is intolerance to the GDMT they're already on. Maybe it's the beta blocker they're on. Maybe it's the other medicines they're on. And then you start withdrawing therapy. When in fact, the reason that the whole chance that you got in this situation could have been potentially avoided if 4 weeks ago you had started an SGLT2 inhibitor. You would have decreased the chances that you had been in that situation to begin with, and you would have increased the odds they would have been feeling better. Instead, they come back with a higher chance of feeling worse. So that's what I mean when it's easy to misinterpret disease state worsening, heart failure progression with actual GDMT side effects. Again, we get ourselves in situations like that when we defer therapies that are proven to prevent clinical worsening. But also when people say, well, how can we start so many medications all at once? I think it's useful to think about other medical conditions where we do just that. So let's take, for example, within cardiology, the average patient hospitalized with a STEMI with new LV dysfunction. Without even thinking, that patient is going to go to the cath lab, they'll get their coronary intervention, and then again, they might be in the hospital for maybe 2 to 5 days, and then without thinking, we're going to reflexively start them on multiple new medications. Maybe they could have been on no medications at all prior to that hospitalization, no prior cardiovascular disease, but now reflexively, we're going to start them on an aspirin, we're going to start them on a P2Y12 inhibitor, we'll start them on a statin. Then if they have LV dysfunction, we also do a pretty good job in many cases, starting them on ACE inhibitor, beta blocker, and MRA. But in contrast, what about that patient hospitalized for worsening heart failure? Over that same maybe median length of stay, 2 to 4 day hospitalization, we follow, generally speaking, a diuresis and discharge mentality. And there's few, if any, initiations or escalations of life-prolonging therapy in routine clinical practice. And that's despite the risk for that patient with worsening heart failure, by and large, having orders of magnitude risk higher than that average patient hospitalized with STEMI or LV dysfunctions. A risk treatment paradox. The worsening heart failure patient needs the help the most, yet they're less likely to get their initiation, escalation of their life-prolonging therapy. But even still, I was used to getting pushback on the idea of simultaneous or rapid sequence initiation until, through last year even, people would say, well, Steve, sounds all well and good. Yeah, I get your points, but at the end of the day, there's no dedicated RCT of simultaneous or rapid sequence initiation of starting all these medications at once. So how do you actually know definitively that it's safe and effective? And up until last year, I used to have to acknowledge, well, technically that is correct. There is no RCT. But at the same time, I was saying, well, there is absolutely no evidence that delaying initiation of any pillar of quad therapy accomplishes anything beneficial. And there's no evidence that delaying therapy improves medication tolerance. But instead, there is evidence that delaying initiation of any pillar of quad therapy needlessly exposes the patient to one, excess risk of clinical worsening and death, and as I showed, the very real possibility of never having the medication prescribed at all. But now, although I still can highlight those arguments and still just did, my answer to this question and this criticism about no dedicated RCT has changed, and it changed last year with the publication of the STRONG HF trial. So now I acknowledge that it was correct using the past tense with this criticism. And STRONG HF was published and simultaneously presented at last year's American Heart Association meeting. And now, for the first time, we have direct randomized clinical trial evidence supporting overwhelmingly the idea of simultaneous and rapid sequence optimization of GDMT for patients with heart failure. So quickly, STRONG HF was an international clinical trial. It took patients hospitalized for heart failure who were on suboptimal GDMT at baseline. And prior to discharge, it randomized them 1-to-1 to one of two treatment strategies. Half of the patients got randomized to high intensity care, which involved prior to discharge, simultaneous initiation of multiple GDMTs. Then the patients were then followed closely over the first 6 weeks post-discharge, where therapy was up titrated to the target dose and they were monitored for safety. The other half of patients prior to hospital discharge were randomized to usual care. So this essentially meant patients just followed up like they normally would. They got the GDMT they normally would. And then the primary endpoint in the STRONG HF trial was at 180 days. And this was looking at all-cause mortality or heart failure hospitalization. Now, STRONG HF was terminated early by the Data Safety and Monitoring Board after over 1,000 patients were randomized. And it was terminated early because of overwhelming efficacy among those randomized to high intensity care. The DSMB decided it was not ethical to keep randomizing patients to the usual care, slow and steady approach. Well, what did GDMT look like in the STRONG HF trial and in the two treatment arms? Well, as you would expect, there were major differences in the use of GDMT in the high intensity care and usual care. This slide shows just the likelihood of patients getting the target doses of GDMT at the different parts of follow-up. And this slide shows full, or at least half of optimal dose of GDMT. You again see there was major differences in the exposure to GDMT over the 90 days and 180 days post-hospital discharge. Well, what did this major difference in exposure to GDMT buy us in strong HF? Well, it bought us a lot. So for that primary endpoint of 188 heart failure readmission or all-cause death, high intensity rapid sequence simultaneous initiation came with a 34% lower likelihood of this hard clinical endpoint. This 34% relative risk reduction equated to enormous absolute risk reduction. 8.1% absolute risk reduction, number needed to treat to save a life or prevent a hospitalization over just 6 months of only 12. But it wasn't just about the clinical outcomes and the clinical events. The patients also felt better with high intensity rapid sequence simultaneous initiation. They had improvement in their patient reported health status as defined by the EQ-5D. They had improvements in NYHA class as judged by the clinician. There's also improvements in congestion, in incremental lowering in NT-proBNP with high intensity care. And for those so worried about safety and tolerability of starting all these medications at the same time, there was no significant difference in serious adverse events compared with usual care. So again, strong HF was really a home run to give everyone reassurance with a direct randomized clinical trial base of evidence now that we have overwhelming evidence to do rapid sequence simultaneous optimization of GDMT for heart failure to complement all the pre-existing evidence and rationale for the approach that I went over earlier in today's webinar. So as we wrap up here, some take-home points for everyone to digest. When you think about simultaneous or rapid sequence initiation of quadruple medical therapy for HFrEF, to recognize that the optimal approach is to initiate each of the 4 medications proven to reduce all-cause mortality in all patients who are eligible, and to start all without significant delay. In contrast, a serial or selective approach, as is the status quo, will unfortunately result in needless or prolonged delays in GDMT optimization, and unfortunately will lead to excess heart failure hospitalizations and excess deaths that could have been prevented with earlier comprehensive quadruple medical therapy. We now have the STRONG HF trial, which provides for the first time direct randomized clinical trial evidence supporting the efficacy and safety of simultaneous rapid sequence optimization of GDMT. And to please recognize that simultaneous or rapid sequence initiation of GDMT seeks to 1, break the culture of clinical inertia, 2, leverage the early benefits of each of the 4 therapies that are fully additive to each other, and perhaps most importantly, to treat this extreme risk condition that is HFrEF with the sense of urgency that it truly deserves. Thank you very much for your attention, and I look forward to any questions.
Dr. Greene, thank you so much. You've got us all fired up about quad therapy and GDMT. I think our new rallying cry is going to be don't just diurese and discharge. So we will now move into the moderated question and answer portion of our webinar by Dr. Vanessa Blumer. As a reminder, you can still submit questions into the questions pane in your control panel. Thank you.
Thank you, Steve. That was brilliant, as it always is. And I think you hit on in a lot of key points. I think, for me, one of the important things about the rapid initiation approach is that it's not just an isolated approach, right? It's also a way to improve, like you brilliantly said, improve implementation and also decrease gaps in care that we have that ultimately just translate into decreasing unnecessary risks that we have into a very high risk population. So I think, that's at least how if we want to be simple, that's how I see it. This is just not an approach of going fast or not. It's just actually getting therapy to those who need it most. I think we have several minutes, I think, for a couple of questions. So if anybody in the audience has questions, I'll be monitoring the Q&A. If not, I have a couple of questions for Steve prepared. I do see one in the chat, which is one that actually I had in mind and wanted to bring up. is, there are some subgroups or some populations that might have a little bit more challenges with this approach. Among them, some people point out elderly population. Do you have a specific approach on how to manage people that can be a little bit more frail or have a little bit at baseline more of intolerance, yet because of their baseline characteristics or because of a blood pressure challenge? How do you go about with those patients?
Yeah, no, it's a great question, Vanessa, and this comes up all the time. I think whenever you're having shared decision making, especially, conversations, especially with our older patients, our frail patients and whatnot, again, based on the data, we need to not only talk to them about risks of potential side effects, we also need to talk about them with the risk of omission. And that is the risk of not even trying a therapy that's been proven to decrease risk of passing away and also improves quality of life, which is something our older and frail patients care a lot about. So again, based on the randomized clinical trial evidence, subgroups of patients that are older age, just as much benefit in terms of relative terms with the GDMTs. Frailty, just as much benefit in terms of compared with placebo. But I think we need to understand, though, that these higher risk groups, like our older patients, they actually have greater absolute risk reduction. So because they're at extra high risk, that same relative risk reduction buys them a lot of absolute risk reduction. So actually numbers needed to treat are lower among our frail patients, among our older patients. And especially when you're talking about our newer therapies like SGLT2 inhibitor, which again are extremely well tolerated. They're essentially blood pressure neutral. They improve quality of life quickly within 4 weeks. I think we really need to weigh the risk of omission with not even trying these therapies. The last point I'll say about older patients and whatnot is that a lot of them are on a lot of medications, and of course polypharmacy is always top of mind in these populations. But to be honest, look at that long medication list, and it's important to realize that not all of those medications are created equal. How many of those medications on that list, that long list that you see in the 85-year-old in your clinic, are proven to be efficacious in randomized clinical trials? How many of them improve life expectancy, even in older patients? How many of them are definitively proven to improve quality of life? How many of them are proven to be safe? Again, the evidence base supporting our GDMTs is so robust compared to the average medication our 85-year-old is on in routine clinical practice. So again, to say we're not even going to try to start these medications, I think patients need to be well informed of the risks of not trying if they meet the eligibility criteria, and not just say, well, you're 85 years old, we automatically can't rock the boat in you. I think that's a disservice to have that mentality.
That's great. I'm really excited because there's a lot of great questions coming in the chat box. And a lot of these questions are questions that I also wanted to ask you. So specifically referring to the blood pressure though, how low are you willing to tolerate a blood pressure? Do you have, I'm gonna ask you several questions regarding the same thing, but do you have a different approach or strategy, maybe in the sequence that you start medications if you know that a patient's blood pressure is already baseline kind of low? And then somebody asked in the chat box, is there a role for midodrine, for example, to allow more room for GDMT?
Well, I'll first answer the midodrine question. Absolutely no evidence that midodrine, if you are able to tolerate GDMT by use of midodrine, whether that's an evidence-based approach, we don't, again, midodrine is a medication that's used all the time. We don't have any, to my knowledge, long-term safety data with that medicine. So again, it's not an evidence-based approach to use midodrine for the purpose of getting GDMT on board. So I don't do that routinely myself. In terms of what GDMT, how low blood pressure we can go, again, the most important thing with blood pressure is if the patient is symptomatic or not. That is the most important thing. So for example, like patients with a blood pressure of, let's say 100, okay? They're eligible for many therapies still, pretty much all of them, including sacubitril valsartan. Now, of course, they might have a higher chance of symptomatic hypotension. You should counsel them about that. But again, we should think about trying the medication regardless. So I'm sorry, I'm having some background noise right here, but we need to be willing to try the medication regardless. And if they're not symptomatic with hypotension, that's a win because we're keeping them on a life-saving therapy. And again, blood pressure is only a number. So again, the most important thing is, are they symptomatic? And if they actually have end organ dysfunction or signs of shock, but if they don't, use the medication with caution, but please do not say we are automatically not able to try the medicine. again, those patients can still be eligible for GDMT.
That's great. And I think that hits on a very important point, because a lot of people are a little bit more hesitant maybe to start in GDMT because the blood pressure is low. And I think it's very key to, get that message across that it's not just a number that we're treating, right? That we should always try to up-titrate and incorporate GDMT as much as possible. How do you go about, and this maybe comes back to the sequence question, but also hits a little bit on side effects. When you do this approach where you're incorporating a lot of medications at once, I think some people are a little bit more hesitant because then you don't know where to pinpoint side effects. What has been your experience to that, and then how do you manage this? And also with the patients, right? Because I feel like then the patients wouldn't know what to attribute their side effects to.
Yeah, I mean, of course, there's going to be the situation where if a patient has a side effect, you don't exactly know which one it's caused by. But again, it doesn't happen as much as we think. And again, we're so worried about these heart failure patients. Yet in so many other medical conditions like diabetes, we use combination pills all the time, SGLT2 inhibitor with metformin, or blood pressure, we're starting lisinopril hydrochlorothiazide. Again, we don't hold these other conditions that have much lower risk to the same standard, or not have the same amount of worry. I mean, honestly, 2 of the 4 drugs, SGLT2 inhibitor and MRA, rarely cause symptomatic side effects, really rarely. They're both essentially hemodynamically neutral. The SGLT2 inhibitor trials included patients with a blood pressure of 95 or higher, so all the way down to 95 to get into those trials. And then when you look at kidney function and potassium homeostasis, they're totally complementary. So that's, one might increase risk of hyperkalemia, one decreases risk of hyperkalemia. So they should work well together. They should be a combo pill, in my opinion. And then with the other drugs, though, in terms of side effects, talking about super low doses. So 3.125 of carvedilol, okay? Sacubitril valsartan, 24, 26. So into my patients, so simultaneous or rapid sequence. If you feel uncomfortable, let's say your patient has a blood pressure of 100 and you're worried about starting medications all exactly on day 1. It's okay to say, let's take these 2, wait 3 days, you feel okay, start the other 2. Okay, that way you can kind of tease out side effects if you're worried about it. I think the patient is particularly high risk of intolerance. But the clearly wrong answer, okay, and I know it's strong words, but I'll say it's wrong, is to start 1 or 2 of them in clinic today and say, I'll see you back in 1 to 3 months, and then we'll talk about the others. We can't do that. Time is of the essence. We have to be willing to make multiple medication changes at the same clinic visit. And if you want to stagger by a few days, that's okay for the medicines like beta blocker and sacubitril valsartan that might have more hemodynamic activity. But again, we have to be willing to make multiple medication changes. The current approach, the status quo approach that is showing the data, it's clearly not working. The last thing I'll say about this idea and just the philosophy is, with the risks of commission, I'll say, in terms of like side effects, for example, we internalize and feel guilty if I start a medicine, let's say I start spironolactone, and patient gets hyperkalemic. And even though they were eligible, they might still get hyperkalemia. And I'm going to be like, oh, too bad, gosh, I knew I shouldn't have started spironolactone. I'm going to be extra cautious next time. But now let's say you don't start spironolactone, and that patient now, 3 weeks later, passes away. Well, then our philosophy in our head is going to say, well, that's just heart failure. That's just, we don't internalize it the same way. We say, oh God, I feel bad, but that's just the patient is really sick. But in fact, we should be thinking that's the risk of not starting spironolactone. So again, we need to internalize and recognize those risks of omission, not just feel bad when we cause a side effect. Patients cannot be passing away and going to the hospital without getting an opportunity to at least benefit from a proven medication.
That is excellent, Steve. How do you have these conversations with patients? How do you approach patients that might be a little bit more hesitant towards starting medications at the same time?
Yeah. So I tell them kind of the same type of things I'm saying in this conversation here, is that I'm their consultant. We work together. My job is to tell you what the data shows and the pros and the cons. And again, it's important to recognize the side effects, and that's oftentimes what patients want to talk about. But at the same time, when you look at the clinical trials, the GDMTs versus placebo. So again, when patients don't know what they're getting, the risk of discontinuation of the drugs are the same really for GDMT and placebo. But again, side effects of course can happen, we need to acknowledge them. But again, I spend just as much time, if not more, making sure they understand the risks of not trying. You know, again, we have a proven therapy. The risk of not trying that medication is substantial. That means higher chances of passing away, higher chances of getting worse. Patients need to understand that heart failure really is a prognosis comparable to many cancers. And of course, we don't want to scare patients, but we don't want to be disingenuous either. And if this was a cancer, patients and clinicians would be eager to start chemotherapy. And we all know about the chemotherapy related side effects that get advertised, things like alopecia, nausea, vomiting, you know, all those kind of things. Patients and clinicians are willing to accept those for treating a cancer. And even in many cases where the cancer therapy has much more proven data and actual proven efficacy. Here we have a condition, heart failure, with the same prognosis as cancer, in a therapy with more efficacy than the average chemotherapy and much less side effects than the average chemotherapy. So again, some patients might not tolerate GDMT, but we need to understand the risks of not even trying a medication that is proven to improve outcomes.
That's great. I think that's a really good way of putting it to patients and maybe just, you know, explaining it in a way that is relatable to them. How does your approach, if in any way, does it vary with inpatients versus outpatients?
Yeah, no, it's a great question. So the philosophy of simultaneous or rapid sequence initiation needs to apply to every patient encounter, whether you're seeing that person in the clinic or in the hospital. But really, for the hospitalized patient, you know, it's not as critical that they all get all 4 therapies right away to the minute on the same day. But the most important thing for the hospitalized patient is that by time of discharge, they get all 4 therapies and are sent home on prescriptions for all 4 of those therapies. Now, to be frank, starting the therapies for a couple days in the hospital does seem to be helpful in terms of improving adherence and persistence. So rather than just like, you know, giving the prescription as they're walking out the door, starting them on the therapy for a day or 2 in the hospital does seem to be helpful, probably because it proves they can tolerate it in a very closely monitored environment, and they get familiar with it and maybe get some more education on it if they're using it for a couple days before they go home. But the most important time point is the time of discharge for the hospitalized patient. So in hospital initiation, whether it's all at the same time or staggered by, you know, every couple days over, let's say, a week-long hospitalization, most important thing is by time of discharge for the hospitalized patient, they go home on the therapies. The outpatient is, you know, again, we need to be willing to prescribe multiple medication changes at a single outpatient visit. But again, if your clinical judgment says they're at very high risk for medication intolerance, sometimes I stagger the doses of beta blocker and sacubitril/valsartan by a day or 2. But again, the idea that you can wait till the next clinic visit, a month, 3 months from now, and then start the next drug, that slow and one step at a time approach is not cutting it right now with our GDMTs. And people are dying and going to the hospital without even getting a chance of benefiting from these proven drugs.
Thank you, Steve. I see a lot of questions in the chat box, and it's an area that I'm particularly interested about is, how do you do this from a practical standpoint? How do you do this? How do you implement this from a practical standpoint? And different questions in the chat box. One of them is, do you partner, for example, with primary care? And should primary care physicians be allowed to actually initiate and uptitrate these medications? What are your thoughts on that? How do you go about in patients that are a little bit maybe more rural and have a harder time coming back to appointments? And then the last piece of this would be, how have you incorporated telehealth? If you feel that there's not enough personnel maybe to be seeing these patients routinely to do the uptitration or initiation.
Yep. No, so it's a great question. So I would argue that the approach of simultaneously starting all 4 drugs is the most practical, simple approach to implement. I mean, it would be much harder to implement if I was talking today about some fancy algorithm where you're gonna do step 1, step 2, step 3, step 4, and see the patients back. I mean, this is literally just like you have a patient in front of you in an office visit. Make sure they're on all 4 drugs. And if they're not in any of the drugs, prescribe it today. Again, I think it's more generalizable because yes, there are places that have limited resources and whatnot in terms of follow-up and all that. But again, we're not asking to contact the patient later necessarily and start the medication then. We're saying you have a patient in front of you today, whether you're sitting in a rural clinic or an urban clinic. Again, they're in front or they're in the hospital with you. Make sure they're on all 4 drugs if they meet the eligibility criteria. And the highest yield approach, again, is the sprinkle mentality, I call it, of initiating or make sure they're on low doses of all 4 of the drugs. Prioritizing low doses, the sprinkle, rather than, let's say, high dose sacubitril valsartan and no beta blocker, and high dose of ARNI, but maybe no SGLT2 inhibitor. Again, the sprinkle approach. So again, I have a patient, let's say, see me in clinic. A lot of patients are already on maybe 1 or 2 of the pillars because maybe they had hypertension or whatnot. Maybe they're already on a beta blocker, let's say. So you're not starting necessarily all the way from 0. But, let's say they're on, carvedilol and spironolactone already. Again, okay, they're on 2 of the 4. I'm going to see them in clinic. They're right in front of me. We're going to just prescribe the drugs. Prescribe an SGLT2 inhibitor, prescribe an ARNI, make sure they're on low doses of all 4. Even if you can't up titrate, okay, let's say because of logistical issues, you can't have the patient back, you don't have the capabilities for telehealth, and you don't have the nursing bandwidth to call the patient and all that stuff, you accomplish so much by just having them on low doses of quad therapy. That's where you actually get the bang for your buck the most. We talked about the early separation of event curves I showed for all 4 of the pillars. That's generally happening when patients are on low doses of the medication. The clinical trials, let's say beta blocker, for example, they didn't just randomize people to placebo or 25 milligrams of carvedilol right away. They got randomized to 3.125 or placebo, and they up titrated over time. But those event curves separating quickly after randomization, that's happening while the patients are on the low doses. So you're getting enormous value and bang for your buck if you can just get people on the low doses of beta blocker and low dose of sacubitril valsartan, low dose of spironolactone or eplerenone, for example. And again, to me, that is the most practical. You don't need a lot of technology for it. You just need to be willing to write multiple prescriptions at the same time.
Wonderful, and I think that was one of the questions in the box is, how important is it to titrate to goal? And I think, we just started first, right? So I think starting is the most important thing, and then obviously focus to uptitrating as much as tolerated. Is there, there's several questions around cost issues, which obviously it's something that we have to acknowledge. Do you have any specific recommendations on how to approach patients that have some limitations with cost, or do you know of any programs out there that can be helpful to patients or helpful to prescribers?
Yep, so no, it's a great question. And as mentioned, for certain patients, this is of course a barrier. Again, I'll get back to the question here, but I do acknowledge though that cost is important for many patients, but again, it is not the reason why we're not using spironolactone or there's huge gaps in ACE and ARB and beta blocker. So it's not the overarching reason. We don't use our non-branded, our generic medications, not just our expensive ones. But for our branded medications like sacubitril valsartan and the SGLT2 inhibitors, what I'll say with SGLT2 inhibitors is now we have actually a lot of competition for this. There's actually multiple agents now available. There's empagliflozin, there's dapagliflozin, there is recently approved now sotagliflozin, and also was approved recently by the FDA for glucose lowering is bexagliflozin. So in bexagliflozin has a deal with Cost Plus Drugs and for $47 a month. So again, it wasn't a SGLT2 inhibitor tried in a clinical trial, but it is, again, we think there's probably a class effect when it comes with an SGLT2 inhibitor. So now we have multiple options with all these different agents available for SGLT2 inhibitor therapy. Again, if empagliflozin and dapagliflozin are cost prohibitive. Sacubitril valsartan, again, it's hit or miss. I find that most of the time we can overcome these barriers and get patients access to it, and there's patient assistance programs and whatnot. But the thing I will say is that for these branded therapies, this is just another reason why initiating in the hospital is so important. Because yes, we talk about if you don't initiate, the chance that you get it at all is substantially reduced and you might never get it. But part of that is probably because there's more resources in the average inpatient setting than the average outpatient setting. I mean, for an outpatient clinician who might be working by themselves on a given day, seeing tons of patients to now have to do, go through the prior auth and, battle with insurance companies and everything to try to get sacubitril valsartan, it's going to be a challenge compared to the inpatient setting where you usually have, even in many rural hospitals, a good multidisciplinary team where you have, nurse practitioners, case managers, social workers, on top of clinicians, all can work together to potentially have the best team to overcome these access and affordability issues. So if there is a possible way to get the patient to therapy, the inpatient team is probably better suited in terms of bandwidth and, opportunity to get those patients on therapy. So another reason why in-hospital initiation is so critical, because there's just more hands on deck and resources for the average inpatient environment.
I could listen to these questions at length, but unfortunately we are at the top of the hour, so I'm going to have to cut you all off. Thank you so much, Dr. Greene and Dr. Blumer, for a remarkable presentation and question and answer session. Thank you everyone for attending. When you leave today's webinar, you'll get an email with a short survey, so please complete that, provide your feedback, and there will be a recording of today's webinar sent out within a few hours. We are going to continue the conversations around quadruple medication therapy and GDMT with future educational opportunities, so please keep an eye on your inboxes. And on behalf of the AHA, Dr. Greene, Dr. Blumer, and all of our heart failure patients, thank you for joining us today.